This is the presentation for the unique challenges of providing emergency medical care to geriatric patients. This period of instruction is brought to you by me, and this is the sixth and final attempt to do so. If this attempt is unsuccessful, you will not see another slide, for I will have broken this computer into 1,000 pieces, and what's left of it is currently on fire sitting atop Austin's desk. This question is actually pretty interesting. Why should we have to pay particular attention to the question of how do we care for this adult population? Because it's not just about the immediate, it's about taking time to look into the future. Consider this. By 2030, the number of people who are 65 and older will be 1 in every 5 Americans. And that'll be because the baby boomers are neither babies nor boomers anymore. They're the new geriatric population, and there is that many of them. By 2034, the number of people at least age 65 will be 77 million. By contrast, the people under age 18 will be 76.5. That'll mean we have more geriatrics than we have adults coming into the prime of their life. That's not an insignificant figure. On this slide, I provided a hyperlink that I think you might enjoy looking at in your own time. It's a humorous way of perhaps showing what providers can feel dealing with so many geriatrics, because one of the goals of modern medicine is to extend a person's life. The trick to it is that it doesn't necessarily mean we've extended the healthful years of their life, and that comes with challenges. So, if you have time, take a look, and I hope you enjoy the show. So, how does Douglas County fit into this? The last census informs us that there's 112,297 people that live in Douglas County. The percentage of that population that's at least age 65 is 26.3%. That makes a grand total of 29,534 folks that are at least age 65. We have a significant pool of geriatrics in our community, and that's going to contribute to a lot of calls. So the information on this slide tells you that Douglas County gets about 30,000 activations a year for fire and medical. It's important to note because that's 30,000 activations that are all potentially medical in a population that's 112,297. That's a yearly one call for every 3 people. That's a significant utilization. This slide is important because it tells us that Douglas County doesn't sift the calls received per age group. And while that's fair, I mean, it's an incredibly large task to do, and if they don't have the software, they don't have the software. But it tells us that we could be serving more geriatrics than at the EMS level directly or at the fire alone level directly. We may not be wholly aware of just how many geriatrics we're encountering on a day-to-day basis. I did get a chance to talk with Tom about UVA's data collection, and a couple of things were important to know. One, that UVA does collect data, and they're able to filter it by call type and by age. A couple of things, UVA runs about 2,000 calls a year, which as an employee feels low, but Tom assured me that's the number. And if you take the average age across all call types, the average age that we served for females was 66 years old, and for gents was 63 and a half. That's telling because we haven't already hit the benchmarks that the US Census kind of warned us about. So before we hit those big peak volumes, we're already serving, on average, a very older segment of the population. This slide is included because it introduces one of the unique challenges to serving the geriatric community. And although this article kind of buries the lead a little bit, the link will be in the reference section for you to read. But what it does say is that the Centers for Medicaid and Medicare avoided a 0.7% cut, saving $125 million from the total budget for that program. Except as you read further down, it says that there's going to be a permanent cut of 3.925%. The math and what that impact is will be on the next coming slides. So some basic math. If a 0.7% increase yields $125 million, then that means that the total operating budget was $17,857,142,857 for the total budget. But if they're going to cut 3.925%, then that means that there's going to be a loss of $700,892,857. That's not insignificant. That means our seniors are going to have less prescription drug coverage, less support for in-home supportive care. The logical conclusion will be we will run on more seniors because they will have less services and less funding for their services. Now, something that was particularly frustrating. The report by KEZI 9 News is that Mercy Medical Center is going to lay off 50 people, but they're going to end their home health care tranche of services. Now, the people that they were going to lay off are the people that are monitoring people inside the ER who require a safety standby, because that's a smart decision. But what it does mean directly for us serving the geriatric community is that those in-home supportive services are going to be missing from them. So they may not get their prescriptions. They may not have their post-acute stay checkups. They will not have the resources they would otherwise have. This will result in more calls and more sick seniors. So get ready to deal with that. So again, to review how these things are kind of coming together to create the problem that we're going to deal with. If our geriatric population is going to continue to grow, and they're going to face significant cuts either to their primary insurance coverage or their secondary insurance coverage, and we're anticipating that we're going to run more calls, what do you think is going to be the logical outcome for you as the EMS provider? And what do you think that's going to mean for Douglas County specifically? How are the services we're providing now measure up against the needs identified in our community already? On this slide, I've pointed out the 5 types of calls that have the highest average age. And for incontinence of urine, the highest average age for females was 90.61 years. For tachypnea, females were 90.63 years old, men 67.51 years. Infection of the urinary cath, females weren't listed, but men were at 89.33 years old. For a swollen limb, females 71.9 years and men 89.87 years. Fractured hip, females 86.72 years and men were at 76.36 years. The point of that is to say that if we have more people reaching those years, we're going to have more calls of this type. Something to consider. When people get of a certain age, they get defined as old. And from the data I showed you on the last slide, we can expect to see in our old population a theme to the types of calls we're going to run on. Cardiac and pulmonary system derangements, infections, falls resulting in hip fractures. The trouble that we have specifically in Douglas County is Douglas County is very poor. It doesn't have a lot of resources. It runs out of resources very quickly. And part of it having a few resources to offer is we have to transport out of town a lot, which again further depletes the 911 system. So think about that as we go about projecting into the future of what more seniors will look like for our county. There's a private sector and there's a public sector response for this problem. When I was speaking with Tom and I was asking about the difficulties of having multiple rigs out for out-of-town transports and how that relates to difficulties responding to the 911 system, he wasn't concerned. He went so far as to tell me that the only reason we have as many ambulances as we have in service currently is because of those out-of-town transports. They're the mechanism by which we have the ability to afford the number of employees that we do. Why? Because the pool of customers that we serve through 911 is heavily weighted towards people that are on Medicaid and Medicare only. And for getting reimbursement for those calls, we don't get reimbursed at 100% of what we bill. And it can take a really long time to receive a dime of that reimbursement, as much as 3 years based off what we were talking about. So the option for private sector is a little bit more adaptive than public. So when I was speaking with Battalion Chief Richardson from Sutherland Fire, his perspective from the public standpoint is pretty telling. That running out of money for your operating budget isn't as simple as waiting for the reimbursements to come in to fuel up your rigs to buy supplies. When the operating budget runs out, that's it. The city has to approve their operating budget on a yearly basis. Any changes to it have to be approved on by voters. Some departments have decided to run their own ambulance, which is great. You get a small amount of money in, but you're never going to build this huge war chest to run calls. It's just not going to happen. Other agencies have done things like pair up with nonprofits or they hire single role medics. but that's not necessarily possible with an ultra-rural or small town population department. The others are, if you ask someone to run a nonprofit ambulance company, you're asking someone to volunteer their time to work a 12, 24, 48-hour shift. It's hard enough to get volunteers to show up anyway. Now you want them to run an extended shift without pay? That's going to be a big ask. So, what do we know? We know that the geriatric population is a vulnerable segment of our society. They have unique medical needs. Brains shrink over time, making them more likely to get a brain bleed. Their bones are less dense, meaning that they're more likely to fall, they're more likely to break something, which can lead to their death. They're more likely to experience seasonal sicknesses way more acutely than someone who's young. Consider the flu season. Large segments of the geriatric population have polypharmacy issues. Rare is it that you're going to find the patient who has one or no drugs. They're a unicorn. It's something we remark on, like, wow, you have like one med? That's awesome. That's not common. The next thing is they typically have a significant medical history. That's going to make them way more vulnerable to an acute incident. So, as we consider the challenges of serving the geriatric community, we have to keep two things in mind: the situation now and the situation that'll develop as we hit those benchmarks that the CDC mentions. Douglas County is a poor county. One of the things that means is that we're going to have fewer services, whether that be community services or limited hospital capacity. We have a fixed number of ambulances, and sometimes they're not all available due to out-of-town transports. Wait times at the ER are long, even for ambulances, because the ER is always the community safety net. Everyone goes there when they need help. 911 for Douglas County is considered a high utilization system. When you combine the number of calls with transport time, it means that the demand on the system is high. If we were just rural, if this was just a concern about the city of Roseburg itself, we would only be considered moderate because of the proximity to Mercy in relation to Roseburg. But we're not. We're dealing with Douglas County as a whole. We don't have a lot of options. And geriatrics often need a level of care that exceeds Douglas County's ability to provide. They have surgical needs, post-acute needs. They have extended rehab needs. Those facilities have a very few number of beds. They're not staffed fully. We have limited skilled nursing capacity. All of these paint a picture that means that we need to be fully aware of what we're going into. We need to do a lot better to prepare for the milestones ahead. On this reference page, if you have the time, take a look at some of the resources. They're good reads. I mean, some of them are pretty dry and a little long-winded, but it's a good read. For the creative element as required, this was a little video done from a sponsor for this